Let's talk about EKG placement. So your patient will oftentimes be on bedside monitors, but if you want a more accurate look at the heart electrical rhythms, you're going to want to obtain an EKG. Usually that's a 12 lead EKG. Remember the arm leads are going to start out on the right arm, white to the right, and smoke over fire, so black over red. And then whenever you're looking at the precordial leads, you remember that V1 you're going to find at the fourth intercostal space. So you'll find the manubrium, that angle of Louis, move lateral, and you're at that second intercostal space, and then move down to the fourth. On the right side is V1, left side of the patient's chest is V2. You'll skip to the midclavicular line to see V4. In between those, you'll put V3, and then you'll move out lateral to the anterior axillary line and the mid-axillary line on that same level for V4 and V5, V6. When you're looking at your EKG, remember we have the rate, rhythm, axis that we're going to be analyzing, and you can calculate the patient's rate. Remember the big boxes, 300, 150, 175, and so on and so forth. You take the number 300 divided by the big boxes, and that will get you an estimation on the rate, although most of the EKG readouts will give you a rate as well. It's good to know how to calculate it. Or you can count the number of QRSs in a 10-second strip and multiply that times 6. When you're looking at the rhythm, you're going to want to describe if this is a regular or irregular rhythm. The axis, you're going to look at the QRS in leads 1 and AVF and see if that is upright. The P wave, you want to make sure that's coming from the right atria. Also make sure that's upright in 1 and AVF and that it's present. You see one before each QRS. And then you also look at the intervals. You're going to look at your PR intervals, make sure it's less than 3 to 5 small boxes. Remember, those are 40 milliseconds each. So 4, 8, 12, 120 milliseconds for that PR interval. And the QRS interval, about the same. And then you can calculate your QTC. That's the corrected QT interval. Usually your machines will do that. A good rule of thumb is that the T wave needs to fall before halfway between these two QRS intervals, and that will tell you likely have a QT interval that's adequate. The T waves are typically going to be upright except for in V1 and V3, and you'll kind of just assess that EKG from a rate, rhythm, axis, just a linear fashion, the same way every time to kind of help you do it the right way each time. Here's a normal EKG. So you notice that they have a upright P wave in QRS in lead 1 and an AVF. So your P waves are coming from the right atrium. Looks like we have a normal axis. And then I would calculate the rhythm. Looks like maybe 300, 150, 100, maybe around 100 for their rate. And then I would look at the intervals and make sure that everything is looking normal. And this does look normal. So what is SVT? Well, another word or way to call this is AV-NRT, or AV node reentrant tachycardia. And what's occurring is typically at the AV node, you have this fast channel and slow channel. And the fast channel will typically propagate that electrical wave quickly down to the ventricles where you get this contraction. Well, in SVT, you have this relative refractory period, and if the slow path actually propagates that electrical activity around during that refractory period of the fast channel, you may get this kind of looping of the AV node. So you get this re-entry of it. So that's why you can have this circular kind of effect of the AV node. And because you are propagating that from the AV node, you'll have a narrow QRS. So that premature contraction causes the slow pathway to start looping the electrical activity around the AV node down the ventricle as well. And you see very regular QRSs that are nice and thin. But you can see here the little waves that we're seeing close to the QRSs are actually not P waves. those are T waves. There's an absence of P waves. This is a fast rate, typically in infants and children. It's going to be high to 100s, close to 200 plus. In adults, you're maybe in the 150s range. And that's how you can identify AV-NRT, also known as SVT. Another important one to recognize is ventricular tachycardia. So you can see these ventricles are contracting. It's not a nice narrow QRS wave. It's a wider. So this is an example of ventricular tachycardia. Here is an ominous appearing rhythm. This is a V-fib pattern. So you have just a fibrillating ventricle. So no organized contractility here. The best way to treat V-fib is by defibbing them. So applying electricity to get those ventricles, those cardiac muscles depolarized and see if you can get an organized rhythm to get them out of this. Let's talk about ways to get a patient out of SVT. So we can apply sinus carotid massage that may kind of help that patient to vagal down. This is something you're not going to apply to patients with carotid stenosis or TIA history or obviously a recent stroke. You'll place the patient in a supine position with their neck extended. You'll locate the carotid artery at the base of the mandible and apply pressure to one side only for 5 to 10 seconds. And the steady pressure will help to vagal the patient down and hopefully get them out of SVT. Some other procedures we can use are the modified Valsalva, and this is really helpful because you can have the patient breathe really hard into a straw or breathe into a syringe plunger, trying to blow, blow, blow for about 15 seconds. And then once the patient's about to take a breath, you will immediately lay them down with their legs up. And as they're taking that breath, all the heart will return, the blood flow will return to the heart, and they will valsalva down. Sometimes the patients will feel quite sick whenever this is happening, but it can be quite effective, actually much more effective than just blowing on a straw and sitting up. That leg up maneuver is really helpful. For pediatric patients who can't do this, you can actually cause the dive reflex to occur by putting a ice water mixture in a bag and putting it on their face. This is kind of barbaric appearing, so I do warn the parents about what's going to happen, but you're placing that right over the top of the nose and the face and not letting them take a deep breath until about 10, 15 seconds. Remove that, and then as they take that deep breath, they may Valsalva down. If those maneuvers don't work, you can administer adenosine to the patient. Typically, this is going to be given through a three-way stopcock. And as you see, the stopcock, you can point this little lever to the direction you want off. So this is currently off, and you can push this small syringe, which is like the adenosine. Some people will turn that lever all the way down, which will open up all these reservoirs. And you can push the adenosine into the patient and then quickly follow that with the flush. Now, you have to be careful when you do that because sometimes you'll push saline up into this adenosine syringe and you may not get the whole medication infused into the patient. Adenosine needs to be placed through a large bore IV that's really proximal to the patient's heart because it has a very short half-life. It works by opening the potassium channels and depolarizes the AV node, and then it allows that SA node to start taking over and get that normal heart rate and rhythm. The adenosine half-life is about 10 seconds because the adenosine deaminase in red blood cells and blood vessel walls breaks it down so quickly. The typical dose is going to be at 0.1 milligrams per kilo with a max of 6 milligrams. And then that second dose, you can double it 0.2 milligrams per kilo up to 12 milligrams per dose. Now, if you are having trouble with that, it may be because you don't have it close enough to the heart, you didn't push it quick enough, and things like that. You want to push a bolus of fluids behind it, about 10 mils of NS, that may help it to get to the heart a little bit quicker without as much breakdown by the adenosine deaminase. If this doesn't work or the patient is stable or needs to be defibrillated, you will grab the defibrillator. Now, whenever we're using this, you're going to be extremely careful because this can shock you. And so make sure you're cognizant at all times where your hands are, where the pads are. And when in doubt, just turn the machine off. So you're going to apply the pads typically across the heart. So this is on the patient's right side and left lateral side. So you can cross the heart or from anterior and posterior. So you'll turn that machine on. You'll turn this first lever, look for the numbers. Most of your machines will look similar to this. Here, the off position is turned here. You can just turn it on as a monitor, or this red is a defibrillator, and green is pacing. Turn it to whichever one you want to use. In this case, we're using it as a defibrillator. So one, two, this asks you if you want to analyze or charge. If you know that you're wanting to charge it, you would select your energy and charge, and then you would say, I'm clear, you're clear, we're all clear, and you would defibrillate the patient. Now, the defibrillation is typically going to occur about 2 joules per kilo, and this is going to be when your patient's like in VFib and things like that. After that 2 joule per kilo, if you're still not reviving the patient or still in VFib, you've done your compressions, you can go up to 4 joules per kilo, max of 10 joules per kilo, or the adult dose of 200 joules. Now that is defibrillating them. If we're in something like SVT, you're going to want to do a synchronized cardioversion. So that's where we're actually watching those QRS waves, and the machine is calculating the perfect time to give the shock so that you avoid a Q on the refractory period, or that T, so no Q on T incident, which can cause them to go into a worse rhythm. So when you're doing synchronized cardioversion, you're going to want to make sure that you have hit the sync button. And so you'll usually see a button that says sync, SYNC. You'll push that, and then you should see a dot over each one of the QRSs as they're coming up. And that tells you the machine is calculating and watching for those. The dose is different from our defib dose. It's going to be a half to 1 joule per kilo. And you go through the same process after that. If your patient needs pacing, they're bradycardic, well, you turn this to the green kind of pacing, and then you could actually adjust your the way you capture, how much energy you need to capture, and also the rate that you're going at. So you would try to capture the heart and then adjust the rate until the patient is no longer symptomatic. Now, in general, you want this using the defibrillator, using synchronized cardioversion to be in a controlled setting. So you're going to want to have the patient on monitors, have them on end-tidal CO2, have them on oxygen, although we try not to use oxygen whenever we're using electricity. So you turn it off temporarily if possible, so that you avoid a shock and oxygen causing a burn to the patient. But then you would turn it on afterwards. You're going to have IV access as well if you have time for it. So hopefully this is a synchronized cardioversion where you have a stable patient, you can get IV access. And then you're going to be walking through your tachycardia algorithms and kind of following it step by step. So hopefully you've kind of reviewed your tachycardia algorithms. You can see here you're looking at your initial assessment, maintaining their airway, putting them on oxygen, and then you're evaluating your EKG. If the patient appears to be acutely altered or signs of shock, and you look at that QRS and it's really narrow, and you do not see P waves, well, maybe they are in SVT, you have IV access, you can give adenosine, or if not, you can try to shock that patient with synchronized cardioversion. Remember, hit the sync button and then use a half to 1 joule per kilo. You can go through the rest of this algorithm as well. Remember, here's your synchronized cardioversion doses of electricity. Here's your adenosine doses, and there's some other things to look at on this algorithm as well. Here's your pediatric cardiac arrest algorithm, looking for shockable rhythms like your VFib or pulseless VTAC. If you have something like asystole or pulseless electrical activity, where the monitor says you have a heartbeat but you don't feel one, you may need to just go down this algorithm, giving epinephrine and then reassessing every 3 to 5 minutes.